Hello and welcome. My name is Lisa Asfahani. I've been a PA in rheumatology for about 11 years now. I received my doctorate in health sciences from H.E. Stills University and my master's of science in physician assistant studies from Loma Linda University. I work in adult rheumatology in a private practice located in Temecula, California, and I'm really excited to be able to bring this information to you. Today, I'll be discussing some of the new ACR guidelines from 2024 pertaining to lupus nephritis. The 2024 ACR guidelines are structured to incorporate updates on screening, treatment goals, and monitoring for our lupus and lupus nephritis patients. The goals of these new guidelines are to preserve renal function and reduce the morbidity of chronic kidney disease, all while minimizing medication-related toxicities. All lupus patients should be screened at least every 6 to 12 months, even if they have no known involvement of renal disease. It's important to know that approximately 30 to 50% of all SLE patients will eventually progress to lupus nephritis. So who gets biopsied? The ACR 2024 guidelines conditionally recommend to perform a renal biopsy on patients with SLE who have high levels of protein in the urine, greater than 0.5 grams per gram, and or impaired renal function that is not otherwise explained. For Class 3 and Class 4 lupus nephritis, there is a conditional recommendation for a triple immunosuppressive regimen in patients who have active Class 3 and Class 4 lupus nephritis. This includes glucocorticoid therapy and one of 3 different choices of immunosuppressive combination regimens. This includes the corticosteroid plus mycophenolate plus Belimumab, or mycophenolate plus a calcineurin inhibitor, or a low-dose cyclophosphamide plus Belimumab. For Class 4 lupus nephritis, there's also a conditional recommendation for treatment with very specific triple therapy as the most desirable for these pure Class 5 patients with proteinuria greater than 1 gram per gram. This includes a triple therapy of glucocorticoids, mycophenolate, and a calcineurin inhibitor. As far as lupus nephritis steroid tapers, there is a conditional recommendation for a lower dose glucocorticoid regimen after the initial IV pulse therapy to minimize the toxicity that is typically associated with steroids. This starts at 0.5 milligrams per kilograms per day of prednisone for a maximum of 40 milligrams a day, and a taper to prednisone, a goal of less than or equal to 5 milligrams per day by the time the patient reaches 6 months of therapy. There are new, strong recommendations for monitoring as well. This includes quantifying proteinuria a minimum of every 3 months in lupus nephritis patients that have not had complete renal response. And there's also a strong recommendation to monitor patients with sustained complete renal response every 3 to 6 months. I hope this has been helpful, and thank you for listening.